I think we'll move on to the next talk. So I invite Dr. Sanjana to talk about chemical injuries. She's uh, she manages the corneal services at Agarwal Eye Hospital, Cochin and Kottayam.
Thank you. At the outset, I would like to thank KSOS for giving me the opportunity of conducting this IC, and thank you for the audience to making up the time to come and attend it. So my topic today is emergency management in chemical injury. So chemical injury is one of the most common causes of visual morbidity in younger patients, and it is up to on us how to manage in those 24 hours so that we make sure that the vision is safeguarded. So whenever a patient presents with chemical injury, it is to be understood that we do not take the history or waste time on clinical examination. Patient has to be immediately made to lie down. Any particulate matter should be removed on lid eversion, double eversion, and a thorough saline wash has to be given. Now coming to the saline wash, the choice of solution is actually ideally the diphoterine solution, which is hypertonic in nature. So hypertonic solutions basically help in reducing the corneal edema and bringing out the solution, all the chemical solutions. So amphoteric in nature means that it can be used for both acids as well as alkalis. In case diphoterine is not available, then we can use balanced salt solution, ringer lactate or normal saline, which are all basically isotonic. Tap water should be ideally avoided and should be used only if nothing is available in a particular scenario for eye wash. Now once a stable pH is achieved, then we go in for assessment of slit lamp and then severity of the problem is documented. So coming to history taking, we should be aware as to what are the common ingredients in which these chemicals are found. So most common substances that we come into contact are ammonia or lime. So ammonia is found in clinical agents, fertilizers or refrigerants, and lime is found in plasters, cements and whitewash. Coming to acids, car batteries are some of the exposure to chemicals, that is sulfuric acid, and this is a very strong acid. Hydrochloric acid, which is seen in swimming pool, is comparatively a weaker acid. So this history taking is very important because each of these chemicals have their own way of acting and the prognostic value is dependent on the type of alkali or acid that is being exposed. So if it is an acid injury, they normally denature and precipitate the proteins and thus create a barrier for further penetration and hence comparatively less harmful. Whereas strong alkalis, they saponify the fatty acids in the cell membrane, thus destroying the collagen, proteolytic collagen, and also releasing proteolytic enzymes, which then becomes a vicious cycle and further damage. Not only the ingredient or the chemical, we need to know the quantity, the duration of contact, area of contact, as well as depth of penetration before we go in to understand the prognostic values. So following the history taking, we go in for clinical evaluation. Now before going to clinical evaluation, we need to know the classification and grading. Now why is this important? To assess the severity of the chemical injury, to approach towards the treatment condition in this case, and also to know the prognosis of the patient with respect to the visual rehabilitation. So Rupert Hall and Duas had come up with a classification, and to summarize, they basically indicate that any condition where there is more than 30% of limbal ischemia leads to a guarded prognosis following chemical injury. So now that we know the gradings, we have to first see for the lid to check for any kind of a thermal injury because these chemicals can be heated also. So if there is any kind of a lid necrosis or any lid damage, once that is done, we go in to find out the degree of conjunctival involvement, where staining is very important along with double eversion. So once we see the conjunctiva, we need to see the limbus. So in limbus, I am 100% sure that this kind of a total limbal ischemia can be easily picked up. But also picking up subtle changes in early limbal ischemia is also very important when it comes to management. So when the cornea is stained, sometimes you may get early PEs seen in grade 1 injuries, or in grade 4 injuries, we may see a significant epithelial and stromal necrosis with stromal hydration. So after the clinical evaluation and history taking, as we have already seen, the immediate phase of management is already done. So then we divide the management into acute phase management that lasts up to 7 days, the intermediate phase for 2 weeks, followed by the chronic phase. So in the acute phase, we have to start the patient with copious topical steroids, even if there is an epithelial defect. So the preferable choice of steroids is normally prednisolone acetate or dexamethasone, as they are stronger and they have a better anti-inflammatory action. After 7 days, we need to stop the steroids, and then we have the collagen taking into action. And these are anti-collagen, and thus then can cause the further melting of cornea. So it's very important to start copious steroids initially, and after 7 days, taper the steroids. Along with that, we have the additive treatment of preservative-free artificial tears, which is at least half an hourly or 1 hourly. Topical antibiotic in the form of ointments is preferred. Anti-glaucoma medications, as these alkalis, when they penetrate, can cause trabeculitis or block in the trabecular meshwork. Topical and systemic vitamin C supplements is a very important part of the treatment, as they have a pro-collagen activity. So topical, if it could be prepared, 10% topical vitamin C is preferred, which is normally given 2 hourly, and orally mandatory 4 times a day has to be given at least for 1 to 2 months. And this can be super added with systemic tetracycline like tablet doxycycline, which is given BD for 15 to 20 days. If you have the provision of arranging autologous serum or plasma-rich platelets, in such cases can be used for grade 4 and above chemical injuries. So, whenever there's a chemical injury, we all know the inflammatory cytokines are released, causing further and further necrosis. So, in case it's a very grade 4, grade 3 and above kind of a chemical injury, we need to immediately take up the patient for surgical management also, which involves epithelial debridement with or without amniotic membrane transplantation, amniotic membrane fixed along with the symblepharon ring, and if this is not possible, if there is significant conjunctival necrosis, then tenoplasty also can be done. So here is a video where a Procera ring is being placed so that there is no symblepharon formation, as well as the amniotic membrane acts as an anti-inflammatory agent preventing corneal necrosis. So once the acute management is done, the next goal is mainly to reconstruct the ocular surface, because by then we have an idea as to what is the extent of damage and how much treatment is further required to reconstruct and visually rehabilitate the patient. So when it comes to reconstruction or chronic management, there are 3 components that need to be handled: the fornix management, the limbal stem cell deficiency to be managed, as well as the corneal scars. So when it comes to fornicial management, the symblephrons have to be released with or without amniotic membrane to form the fornix, as well as lid reconstruction, so that the extraocular movements are comfortable. Coming to limbal stem cell deficiency, depending on unilateral or bilateral exposure of chemical injury, we have the conjunctival limbal autograft, we have the live related autograft, but the latest that we prefer is the simple limbal epithelial transplant, which has very high prognosis as well as better surgical outcome with less requirement of any kind of a laboratory conjunctival cells. So here is a picture. We have had previous sessions where they have spoken about SLET in detail. Now coming to chronic management in scar of the cornea, we can either do DALC in case of superficial corneal damage. We can go for an optical keratoplasty, or if this does not work and there's frequent failure of the keratoplasty because of limbal stem cell deficiency, we may even have to go for a Boston K-Pro. Thank you.
Thank you, Dr. Sanjana, for that amazing talk.